Hi, everyone, and thank you for joining us today. My name is Richard Mollett, and I am the Executive Director of the Long-Term Care Community Coalition. Today's program is Arming Yourself for Advocacy, and Eric Goldwine and I are going to be talking about some of the resources and information that we think are useful to support resident-centered advocacy, whether you're a resident, family member, ombudsman, or someone who is working with residents and families. A little bit about the Long-Term Care Community Coalition. In case you don't know, we are a nonprofit, nonpartisan organization dedicated to improving care and quality of life for elderly and adult disabled people in nursing homes and assisted living. We've been around for 32, this will be our 33rd year actually, since 1989. I've been with the organization, since 2002. And our focus throughout our time has been on policy research and analysis. So a lot of the things we'll talk about today, talking about the information, the data that we have on nursing home quality and nursing home care, as well as the rules and the standards and how those rules can and should be effectuated in the lives of residents. That's really the heart of what we do. And then based upon our research and analyses, et cetera, we do systems advocacy. And we advocate for implementation, for realization of residents' rights, good care, good quality of life, and dignity in the lives of residents. Because it's honestly so challenging to get change, both in terms of oversight and in terms of the law, we have turned more and more over the past, I would say 10 to 12 years or so, to doing public education programs such as this. Some of the materials that we'll talk about today, that I in particular will be talking about today, to help equip residents and families and those working with them, including, of course, long-term care ombudsmen, who are such an important source and resource, to equip them with the information and the tools that they need to effectively advocate both inside a nursing home and outside a nursing home. Lastly, we are the proud home of 2 local long-term care ombudsman programs in our home state of New York. Both of them are in the Hudson Valley, and I am really very happy that we have that opportunity to house those programs. It's, as I mentioned, such important work. Lastly, and I will talk about this or mention a number of times, our website is NursingHome411.org. All of our resources are up there. Every resource is free to use and to share. Next slide, please. So today's program, as I said, we're going to be talking about arming yourself for advocacy and leveraging some of the resources and information that we provide on our website, NursingHome411.org, for advocacy for nursing home residents. Today's program is very much focused on nursing homes. We do, of course, advocate for residents in assisted living and other types of adult care facilities, but this is really focused on the rules and the laws and the data that we have on nursing homes. And I'll just quickly say, people who live in adult care facilities such as assisted living, adult homes, family type homes, et cetera, many of them more and more over the years have become just as vulnerable, have similar needs, similar abilities as those who are living in nursing homes, including, of course, issues with dementia, cognitive, et cetera. The reason why we tend to focus more on nursing homes is because the rules for nursing homes are frankly better. The information we have on the quality of care and what's going on in the lives of nursing home residents is better. So a major part of our advocacy, not the subject of today, but a major part of our advocacy is how to improve care and quality of life for assisted living. And that will actually be the topic of our webinar for February, which we'll talk about very briefly at the end of the program. So I'm going to get us started today. I'm going to talk about some of the rules, requirements, and resources for resident advocacy that we have on our website and that just in general you can use. And then Eric is going to dig into some of the data that we provide, facility level data, excuse me, community data, state and federal data that can be useful to also support your advocacy. So I always like to start, and especially here, with some background on the rights of nursing home residents, the expectations for nursing home care and services. And as I said just a few moments ago, that significantly distinguishes nursing homes from assisted living and adult care facilities, but also from hospitals and home care, et cetera. That the nursing home reform law, as I note here, also known as OBRA 87, it's the federal nursing home reform law, that recognizes a couple of important things. One, that nursing home residents tend to be very vulnerable. And two, that nursing home residents live in the facility. It is a home, it is their home, and that they rely on that facility for all of the, or pretty much all the services that they need to live, and the clinical services, the emotional supports, the psychological supports, and the quality of life services, that all comes from the nursing home. And is required to come from the nursing home, excuse me. So the reform law, which to my mind is a really special law because it talks to what the nursing home is required to provide for residents. And in short, as I note here, it's required to provide care and quality of life services for each resident that are sufficient for he or she to attain and maintain his or her highest practicable physical, emotional, and psychosocial well-being. Practicable, importantly, is not practical. I know practicable, as I just jumbled it, can be a little bit of a mouthful. But what it really means is that the nursing home is charged, the nursing home is required to be understanding what the resident needs, understanding what the resident needs clinically, understanding what the resident needs emotionally and socially, what they like to eat, what things that they like to do, when they like to wake up, when they like to go to bed, whether they prefer a bath or a shower, any issues that they may be having with their care, et cetera, and be responding to them and providing the services that each resident needs individually in order to achieve what they could achieve at their highest practicable level as an individual. And I think when my Aunt Hilda was on a nursing home several years ago, and I used to go to visit her, and my mother and my aunt would kind of laugh that Hilda was close to 100 years old, and she was getting occupational therapy. And I said, oh, what kind of occupation is Hilda going to have? She's almost 100. But the occupational therapy was helping her to maintain her ability to walk. I remember the aides or the therapist would be taking her up and down the hallway, so that Hilda's ability to walk, to ambulate, didn't degrade because the nursing home was not providing the services, that she was able to, again, maintain her highest capacity, et cetera. So as we know here, the emphasis in the law is on individualized resident-centered care. What does Hilda need? What does Sam need? What does Josh need? Not, this is my nursing home, I have 100 beds, I have 95 residents, and this is the amount of care I'm willing to provide. This is the amount of services I want to provide. This is my bottom line. I want to make a 12% profit this year. So based upon that, this is what's left over to provide care. No, that's not what nursing homes are paid to do. That's not what they, frankly, agree to do voluntarily when they become certified under Medicare and Medicaid. They agree to provide this level of care and services. And importantly, as we know here, it's both clinical care, but it's also quality of life. It's also resident dignity. Next slide, please. So what I want to do is I just want to touch upon a few aspects of the law, just to kind of plug in. Now, as I said at the start, this program is really focused on the resources and how you can leverage the resources that we have on our website. Again, everything that we have is free to use, free to share. If you want to take it and copy part of it and use it under your own name, that's fine. Our goal is to get the word out, to get the information out, to get the resources out, so that residents are able to achieve better care and quality of life. So here's just a few just little blurbs or excerpts from the law or the regulations themselves. This is really regulations, excuse me. So one, in terms of resident dignity, this says the facility must promote care for residents in a manner that maintains or enhances each resident's dignity and respect in full recognition of his or her individuality. This is not my language. This is not what I wrote. It's not my opinion. It coincides with my opinion. This is the regulation, again, that every nursing home agrees to meet or to exceed when it voluntarily takes Medicare and or Medicaid patients. And that's virtually every nursing home in the country. Another one, facility promotes and enhances quality of life. A facility must care for its residents in a manner and in an environment that promotes maintenance or enhancement of each resident's quality of life. I want to take a moment here just to kind of step back. We did a lot of this work several years ago. I pilot tested some of our materials with two family councils here in New York City. And one was in a not-for-profit facility, one was in a for-profit facility. And I went to family council meetings every month for 18 months and talked about some of these residents' rights. And the reason why I want to mention that here is I remember when I spoke about some of these residents' rights, that family members, at a couple of meetings in particular, got really upset with me. And I couldn't understand why they were getting so upset with me personally. And I was speaking to them after the program, and they said to me, this is not anywhere near what their loved ones in the facility was experiencing. That what I was talking about was totally different from how their residents were being treated and how their residents were living. And they were angry, and they were right to be angry because this is unfortunately very distant from what we've seen. I've been a family member several times in my life of a nursing home resident, and I know that these things can be unfortunately very rare. So how do we balance? How do we kind of compute what the law and the rules are, and the disconnect between them and what we see in the lives of so many of our residents? And I think a couple things. One is that, as I said to them then, it's very difficult indeed, no one's saying it's not, to advocate for residents in nursing homes and to improve care. However, the only way that we can make sure or get rights of residents implemented in their lives is if we know what those rights are. And so many people, including my own family members, have accepted care that is substandard, accepted it as a matter of course. And I've seen so many people that have lived lives in nursing homes that have been really crummy and that are really demeaning and oftentimes dangerous. But the only way that we can make a change there is if we know what we have a right to expect. And then secondly, is that we can use this information to advocate. And I know that over the years since we first started doing this, that family members and residents have used our materials and fact sheets to advocate, even within a facility, to say, look, this is what my right is. How can you help me achieve it? But also to file a grievance, to file a complaint, to work with the Ombudsman program, for the Ombudsman programs to know what those rights are and to help residents achieve those rights as well. And then lastly, on this point, this can be informative and empowering for resident and family councils. And there are studies that have shown that having in particular, I'm thinking of one study that showed that facilities that have a strong family council, the care for residents tends to be better. And the care for all residents tends to be better, not just the residents who have a family member on the family council, but the care for all residents in the facility tends to be better. So it is challenging. It can be certainly be heartbreaking, but knowledge is it's a banal thing to say, but knowledge really is power, and knowledge can be empowering. And that's what we hope to do with our resources. And that's really the point of today's program, and frankly, so much of what we do. Next slide, please, Eric. So I'm not going to go through all of these, but there are standards, and these again are just a few of many standards. There's standards in regard to, on the lower right-hand side, sufficient nurse staffing on a 24-hour basis. And this again comes directly from the federal rules. The facility must provide services by sufficient numbers of each of the following types of personnel on a 24-hour basis to provide nursing care to all residents in accordance with resident care plans. And those types, what I didn't include it here, are RNs, LPNs, and CNAs, LPNs or LVNs, depending upon where you are. So the basis for good care, the basis for staffing is there. It's really just a matter of how, not just, but it is a matter of how can we push the envelope? How can we get facilities implemented? And it's something that we're working for. We know many of you are working towards, and it's an uphill battle, but it's not a battle without triumphs. It's not a battle that we haven't won in small parts. I mean, just the fact that there's a reform law in 1987 really speaks to the people who came before me, well before me. Many of whom are still here, still working in this area to ensure that the rules are in place and the systems in place to ensure better care. So here we are again trying to move that forward. Next slide, Eric. So those are just a few of the rules. What I wanted to quickly talk about is the first resource that we have on our website, which is a guide, a primer on nursing home quality standards. Next slide. So this primer, again, as I've mentioned with everything else, is available on our website, and it's free. I think if you just go to the website and search primer, P-R-I-M-E-R, you'll get the primer itself as well as some other resources connected to it. But the table of contents, and this is the page, the table of contents, has descriptors for each one of the standards that we focused on. So we actually had an intern several years ago who went through the federal regulations and identified just under 50 or so regulations that we thought were most important, most critical for resident care and quality of life. And thank you, Casey has posted a link to the primer in the chat. And what we have here are descriptive titles for each one. So if you go to the primer, you can just scroll down here and you can see there's general residence rights, but there is privacy, there is quality of life, there's freedom from abuse and neglect, there's the standards related to pressure ulcers, to mental and psychosocial treatment, etc. So there's a lot there, and you can just click on that page, or click on that line of the table of contents, and it'll take you directly to the page. So it's an easy way to get information. It's available on our website, as I said, and this is the front of our website because I wanted to take everyone through a few other of the items that I thought would be of interest and, again, supportive of resident-centered advocacy. So this is the front page of our website. You can see on the top, on the upper right-hand side, there is a search button. Below that, there is the Learning Center, which I'll focus on today. There's a Data Center, which Eric will be looking at. Thank you, Eric. And then there's News and Reports, and then we have a special section on long-term care in New York. And as you can see from the buttons below, it takes you, there's one button that takes you directly to the Learning Center, another one that takes you to information about long-term care, about nursing home care specifically in your state, and the data and the information that we have there. So we always try to, because it's, we have a lot of information, as you can imagine, and those of you who've been to our website, a lot of data, fact sheets, et cetera, some of which I'll talk about today, but we try to provide as many ways as possible to connect you with what you are looking for. So Eric, why don't I share my screen now, and we can, thank you, and oops, I am going to, sorry about that. I am going to share my screen, and I'm going to take you to the website. I thought it would just be nice for us to kind of go through it. So this is, I'll just quickly go back to our page. This is our homepage, which you just saw before. This is the Learning Center. And you could go through a drop-down menu. So if you wanted to see a webinar program, podcast, Dementia Care Advocacy Toolkit, some of the things I'll be talking about today, and then some of the things Eric will be talking about are here, the state data, et cetera. But this is our Learning Center page. And again, you can see the webinars, fact sheets, family and ombudsman resources, resident advocacy, abuse and neglect resources, dementia care resources, et cetera. So I'm going to go first to the dementia care and antipsychotic resources. We put this resource, this was actually when I mentioned doing the work with the two family councils that were very generous, frankly, to let me come to their meetings, participate, and to pilot test some of this work for an 18-month period. We put together, as a result of that, a dementia care advocacy toolkit. And this was supported by the Fan Fox and Leslie R. Samuels Foundation, which not only supported this work, but really it was, as I said, the first step towards us doing what I hope is valuable work for residents and families, ombudsmen, et cetera, on residents' rights, the fact sheets, et cetera. So this is our dementia care advocacy toolkit. And we have a lot of different information on what on dementia care standards, on the use of antipsychotic drugs, because there's been a lot of, unfortunately, data now showing that at the time when we did this, 1 in 4 residents being given an antipsychotic drug, quite often used as a chemical restraint, as a way to sedate residents in the absence of sufficient staff or appropriate staffing to meet their needs. That has since gone down since 2011, 2011-12, when we were doing this work. And since the national campaign started in 2012, it went down to roughly nationwide, I think about 18.5% antipsychotic drugging rate, which is still very, very high, much too high, frankly. But it started going up again during the COVID pandemic. We assume because nursing homes were not providing the care and quality of life services that residents needed, and were instead giving them medication, and these are dangerous medications to make them easier to care for. So we have a lot of information here. I'm not going to go through the fact sheets now because we're going to talk about a couple of the fact sheets next, but you can see there is a lot of different information here that can be helpful and hopefully a useful resource for you. So I'm going to go to the fact sheet page now, just so you can see what that looks like. Again, you can search up here in the toolbar for if you're looking for something on the website. But here are our fact sheets. There's a lot of them. Go down. And this includes the fact sheets on dementia care, as well as additional fact sheets that reflect some of the, pretty much, I would say almost all of the rules that we covered in that primer. So the primer is one good large resource. The fact sheets can be really useful. Virtually all of them, except for I think 2, are 2 pages long, the front and back. So I'm going to just look at one really quickly. The which one did I want to look at? Resident care. This is resident care planning, standards of care for resident well-being. And hopefully this will open up in just a second. I'm going to try to reload it. There we go. Okay, so hopefully you can all see that. So you can, you can see here, download anything from our website, including this. But this is our fact sheet on resident care and well-being. It includes information about quality of care and activities of daily living, and a little bit of information here, or a little form that you can use regarding maintaining physical and emotional well-being, a small checklist, again, just to make this as useful as possible. I just want to quickly show you the format. Let me see if I can make that, there, I can make that bigger. So you can see, so every single fact sheet, even though it covers a different topic, has the same format. And what we do for all of them is you can see here in purple, we have, again, that descriptive heading, just like we had in the primer, of what it is, what is the topic that is covered, what is the topic, the regulatory topic, excuse me. And then next to that in brackets, we again always have this, are two numbers. One is, as you can see here, the number is 483.25. That's the section of the Code of Federal Regulations from which the regulation comes. And the second is called an F tag. This is F685. Excuse me. And that's the designation that a surveyor, an inspector, uses when they cite a facility for failing to meet this specific requirement. And we include this information for a couple of important reasons. One is because, as I used to say to those family members when I would come in and talk about care standards with them, said it shouldn't be that some bald guy came into your family council meeting, a couple of months ago and told you have these rights and gave you the sheet of paper. With the 483.25, you have the actual citation. So if someone in a nursing home, the administrator says, what makes you think that your resident has that right? Or if you call up your state Department of Health and they say, this is not a regulation that we are responsible for monitoring, you can say, no. This actually is a regulation. Here's my proof that it's a regulation, because you can see the language here, quality of care, everything is either directly from the rules or from the rule language, or it's been lightly edited, but you could always go back to 483.25, just look up Code of Federal Regulations 483.25 online, and you can actually find that. You 99.99% of the time won't need to do that. But at least this gives you the backing to say, no, this is not just something I'm making up or something somebody told me that was their opinion. This actually comes from the rule. So that's why we include the code citation there. The reason why we include the F tag number is because when a facility is cited after its annual inspection or after a complaint investigation, when a facility is cited for violation, and unfortunately most facilities in our country have, I think it's an average of 7 or 8, I'd say 6 to 8, let's be on the safe side, violations per year. It's just violations that are found, not necessarily violations that aren't found. That's a whole nother story. But violations that are found, when they're cited, that citing, is put in what's called a statement of deficiencies. And under the federal law and the federal rules, every state has to have a website which includes the statement of deficiencies for every single nursing home. The most recent, usually it's the last couple of years, but it has to be there. In addition, Medicare.gov / I think it's care-compare, but care compare for nursing homes also has in its facility listings the statement of deficiencies. And lastly, every facility is required to provide a copy of its latest statement of deficiencies. So the statement of deficiencies, when a facility was cited here under quality of care, includes pressure ulcers. And I'll just read this very quickly. Based on, this is again the federal rule, based on the comprehensive assessment of a resident, the facility must, not may, not can if it feels like it, not if it has enough staff, the facility must ensure that a resident receives care consistent with professional standards of practice to prevent pressure ulcers and does not develop pressure ulcers unless the individual's clinical condition demonstrates that they were unavoidable. In addition, a resident with pressure ulcers must receive necessary treatment and services consistent with professional standards of practice to promote healing, prevent infection, and prevent new ulcers from developing. As I'm sure many of you know, pressure ulcers are unfortunately rampant in nursing homes. Not all nursing homes, but in too many of our nursing homes. And the rate of pressure ulcers is very, very high, even though for the most part, they are avoidable and or treatable. So this is something that unfortunately too frequently is a standard that is violated. So if that standard was found to have been violated in a nursing home, your nursing home or a nursing home in your community, they would be cited with F685. And that's really useful information for residents and families and ombudsmen and those working with them to have, because you can, again, you can get your facility statement of deficiency online, in person, and you can use that to say, okay, you were cited for pressure ulcers last year. What are you doing to improve your practice, to improve your monitoring, to improve your care for residents, to ensure that those deficiencies have been corrected? So that FTED can be really useful, because if you go to your facility's statement of deficiencies and you see F454, F685, you can then take it back to our website and get that information and use this information to inform your advocacy, to inform your expectations, to inform what you should be aware of, because you know now that the facility has had deficient practices in this area in the past. What is being done to make sure that you or your loved ones or your residents are not facing the same challenges again. So that's, again, every fact sheet, except for just a few or 2 pages, you could download it, you could print it out. You're welcome to highlight and take out. We know that family and resident councils use some of these. I'm going to quickly go through, let me see. I don't want to take up too much time because I want to make sure that there's time for Eric, and I'm running through it. So I'm going to skip over some of the other fact sheets that I was going to talk about. And I want to go to the, I'll take you there right now, to the Family and Ombudsman Resource Center. And we're constantly working to improve. One thing we're going to definitely be doing over the next couple of months is coming up with some more resources here to really flesh it out. But again, this is another way in which you can get to the information that I was talking about. So here, the first box, first button, you can connect you to the fact sheets that we just came from. So you can go back to that fact sheet page. Fortunately, now I can't see my, hold on one second. Sorry about that. You can go to the Dementia Care Advocacy Toolkit. You can search for staffing levels in your nursing home, some of the data that Eric is going to talk about. We have on the upper right-hand side, Family Council Zoom meeting request. We provide free Zoom rooms, completely private, to family councils that wish to meet via Zoom. So you can go to our website here, click on that, and you can make arrangements for a free family council Zoom meeting. We strongly encourage you to do that and to share that information. And before I move on, I was talking about Aunt Hilda. That's my Aunt Hilda, and that's my mother several years ago. Hilda passed away several years ago. I want to talk quickly about some of the forms and tools for resident-centered advocacy. I can, again, access that here, as you can see, the button on the right-hand side, or I can go back to the Learning Center and go to the, I should have been more careful, Family Ombudsman Resource Center, reporting. I'm just going to do this. I thought we had a separate thing. Here you go. So these are some of the forms and tools for resident-centered advocacy. And I'm actually going to go back to the program now, because I think if I click on one of these, it'll just download, Eric. So if you can, I'm going to stop sharing. And if you can reshare, and we can go back to slide 18, please. That would be great. And then I'll wrap up. Those are just some of the fact sheets. Oh, here we go. So I want to, thank you, Eric. So I wanted to just show quickly some of the fact sheets and materials that we have. So this is the fact sheet, resident and family record keeping. So we put some information on the left-hand side, why you should keep records, what kind of records to keep. And then here is a record for some of the record of resident preferences and a record of problems and concerns. And I think we have a little bit more on that. If you go to the next slide, please. Yeah, you know what? Your numbers are different from mine. I think that's why you got a little confused. So it's resident preferences. There we go. So this is the full, well, not the full, but it's the front page of the resident preferences form. And very quickly, the reason why we did this, and there's several pages, you could fill in as little or as much as you want, is because I know a lot of residents, especially residents who have cognitive issues or dementia, that they may not always be easy to, may not always be able, to communicate effectively their preferences. Sometimes they may be exhibiting the so-called behavioral and psychological symptoms of dementia, such as, being upset or being depressed, or acting out in some way. And this is often the time where we see facilities giving residents inappropriately those antipsychotic drugs as a chemical restraint. We put together this preferences form so that the facility can, if you choose to have this, they can look and see, okay, what is music that Mrs. Smith likes to listen to? Maybe that will be comforting to her. What are some activities that Mr. Alvarez likes or doesn't like that we should know? Oh, you know what? He doesn't want to be in the TV room when there is a ball game because the noises, he doesn't know he's not cognitively able to tune in to the TV. And so he just finds the noises disturbing. So let's find something else for him to do. So these personal preferences can be really useful to let people know about you or let them know about your resident. And these are available on, again, that's just the page we came to. The next one, this is, again, an elongated version, or the full version, I should say, of the resident concern or complaint form. And the reason why we did this, and this really also comes from the work I did with those family councils several years ago, is oftentimes a family member would come up to me after the program and say, my sister has been experiencing something, X, Y, Z in this nursing home for months. And they complained to the nurse on duty. She said she would take care of it. She did, but then, of course, a week later, everything started happening again. And my feeling was that is, of course, valid, and it's, of course, legitimate. However, if you are filing a complaint or making a complaint, even internally within the facility or externally with an ombudsman, with your state health department, with your state Medicaid fraud control unit, et cetera, it's much more helpful to know when something happened, who you spoke to, and what the outcome was supposed to be. And so we put together this really simple form that just does that. What was the date? What was the issue? Who did you speak to? What was supposed to happen? And that way, it's not, oh, this has been going on for months. It's, okay, on March 15th, I spoke to somebody. Now it's June, and this is happening again, and my resident is in pain. What can we do to overcome these issues? So we thought that would be really, really helpful. Next slide, please. The last two things I wanted to leave you with is, this is our fact sheet on resident assessment and care planning. And this was I think by far, the most popular of the fact sheets that we developed with that initial program on dementia care. It talks about what goes into a resident assessment, what is required. And you can see on the left-hand side, what must the facility do? Again, not my opinion, not what I think is best personally. This is what the federal rules say have to go into a resident assessment. And then following that on the second page is what has to be part of the care plan. And again, I'm sorry we don't have time to go into it, but you can easily find this on our website. And that gives you, again, the tools to support. If a nursing home says, oh, we had a resident assessment, we had a care planning session, and it's going to be at 2 p.m. next, on Tuesday. I hope you can make it. And like, I can't, I have to work. And they said, too bad. No, they have to be providing meaningful access to the resident and the resident's representative and the care plan, the care team to be participating in this care planning, because that is what care and services are based on for the individual residents. Everything that we've been talking about, everything the federal rules talk about, is really based upon implementation through assessing the residents' needs, clinical, psychosocial, et cetera, and implementing them through the care plan. So I'm going to leave you with the last slide, which is just a resident assessment planning form, so that families and residents and those working with them can use this form in advance to identify issues. Because I know, and I've been here for almost 20 years now, I know that, when I was started off in my early 40s, if I went to a doctor, the doctor said, how's everything doing? I'd say, okay, I'd forget that, my knee was bothering me, or, I had some other issue. It's hard to remember those things. And now I'm pushing 60, and it's, it hasn't gotten any better. I forget. So I need to, write things down. And so I need to write things down in preparation for my medical appointments. So certainly someone who's in a nursing home and someone who is totally, experiencing, one is, of course, has a high level of needs. That's why they're in a nursing home, but also that vulnerability that they are depending upon the nursing home almost entirely, if not entirely, to meet those needs. It's really important to know and to be aware of and to be able to articulate as effectively as possible what your needs are, what your desires are, what your wishes are, et cetera, in the hopes that they can be implemented. So Eric, I'm sorry, I went longer than I expected. And maybe, because I want you to have time as well, maybe we'll go a little bit over. Eric, you can go to maybe 2-ish, and then we could spend another 10 minutes on Q&A if that's okay.
Thanks, Richard. Yeah, there's a lot to get into when it comes to advocacy.
My apologies.
And I think it's important to both have the information, like the fact sheets, the knowledge of the regulations, have these resources at your disposal. But it's also important to have some data at your disposal. So that's what I'm going to talk about. I'm going to give a brief introduction, and then I'm going to talk about our staffing resources, our provider info data set, our antipsychotic drugging data set, and then I'll just wrap it up with some general thoughts on using data to drive your advocacy. So first, why do numbers matter? I know for some of us, data numbers can come pretty easily. Others, it can be intimidating, but data is an important piece of the puzzle. If you're talking to an administrator complaining of staff time, it's going to be more powerful if you, instead of saying this nursing home is understaffed, if you have the numbers at your fingertips and you tell them this nursing home is averaging 2.4 hours per resident day, and there's very few RN hours, there's no dietitian, and if you can hand them that data set, those numbers, and if you can tell them there are 50% of the residents being administered antipsychotic drugs, and if you have the data to back that up, your case is going to have a lot more power. So we can use these data to support advocacy at the individual and systemic level, whether you're talking to a nursing home staff, whether you're talking to legislators or other family members as you figure out a plan to address some of these issues. So just as an example, you might ask a nursing home or might be able to identify whether a nursing home is providing activity staff. You can see whether a nursing home has a history of deficiencies, and you can see whether a nursing home is administering dangerous antipsychotic drug rates at a clip higher than should be. So nursing home staffing data, it all starts at staffing. This is the most important, it's one of the most important metrics when assessing nursing homes. And nursing homes with higher staffing levels are better equipped to meet their residents' care needs. And federal nursing home requirements mandate that nursing homes have sufficient staff to meet the clinical, emotional, and psychosocial needs of every resident. So remember that: clinical, emotional, and psychosocial needs. Our research has consistently found that most nursing homes in the United States are understaffed and fail to meet the 4.10 HPRD, hours per resident day, that is needed as determined by a landmark federal study. A quick note: you'll see HPRD, you'll see us reference that a lot. This is a staffing metric that it's a staffing ratio calculated by divided a nursing home's daily staff hours by its census. So as one example, a nursing home averaging 300 total nurse staff hours and with 100 residents would have a 3.0 total nurse staff HPRD, because 300 divided by 100 is 3.0. Our magic number, of course, it's not perfect, but the 4.1 is the number that we want to see. If a nursing home is providing less than 4.1 hours, that is a sign that it is not fulfilling its obligations of meeting the residents' care needs. So at the end of this, I'm going to do a quick tour of the website, but in the interest of time, I'm going to just briefly show you what the staffing reports look like and what the different data sets looks like. So this is our latest staffing report from the second quarter of 2021. Here you'll see the summary data, that is what is going on at the national level, how many total nurse staff hours, how many RNs, and you'll also be able to download individual state files. So say you were from Alaska, you could click Alaska on this list and you'll be brought to the Alaska state file. And within these files, you'll be able to see the nursing staff, such as the RNs, the LPNs, the CNAs. You'll be able to see contract staff levels. You'll be able to see non-nursing staff. So is my mother's nursing home having any activity staff? Is there a dietitian? You'll be able to find this information. You'll be able to also examine state comparisons. So say you are a Michigan resident, you can see how Michigan ranks compared to other states. Now, this is what the file looks like. I know it's hard to see with this in this PowerPoint presentation, but once you download a state file, you'll be able to sort it by county, by city. You'll be able to rate it by highest to lowest nursing staff levels, and you'll be able to look at your individual nursing home by hitting that little triangle on column B and searching your nursing home. And from there, you'll be able to see the nursing home staff levels. You'll also be able to see other information besides the RNs, the total nurse, and what we see as some of the really important indicators. But there's also other important indicators such as medical director, dietitian, therapist, that is available in the non-nurse tab found at the bottom of the page. And we use the same structure in all our data sets. There's some slight differences, but they're all sortable, they're all filterable, and you can look at different categories. So if you learn how to use our staffing data set, that'll help you when learning how to use other data sets. So what can I do with this data? Why should I care whether this nursing home has a 5.2 HPRD or a 2.6? What does it even mean? So you can learn really important information, such as the staffing level, such as the nursing home's dependence on contract staff, such as the different non-nurse staffing position. And you can use this information when you are talking to staff. You can ask them, hey, I noticed that there's not a dietitian in this nursing home. Why is that the case? What are you doing to address this issue? You can talk to your legislators by And you can bring these numbers up when talking to legislators, when you're saying, hey, nursing homes in your area are understaffed. And instead of just saying they are understaffed, you can give them a precise number and you can send them this information. And you can also raise these issues at your family council meetings. So again, if people are kind of getting a sense that there's something not right, there were no staff last week, you can actually find this information and see if there's actually data backing up your observations. So quiz time, we'll go briefly through this. So 2 questions. Nursing homes are required to have sufficient staff with the appropriate competencies to meet every resident's A, clinical needs, B, emotional needs, C, psychosocial needs, and D, all of the above. Then the second question is the necessary threshold for total care staff as determined by a 2001 federal study is A, 4.1 HPRD, B, 2.0 HPRD, or C, nursing homes don't need staff time. And I'm going to give we'll go 10 more seconds. All right, so in the interest of time, we're going to end the poll. And congratulations, 81 of 84 of you got the first question right, and that is all of the above. And 92% got the second question right, and that is 92%. So moving on to provider info. This is another very important data set that includes important information such as nursing home ratings, ownership type, whether a nursing home has a family council or a resident council or a history of or an abuse icon. And you can get to this by going to this link above, which Casey will add to the chat. And you can download the national data set here, or you can go to different states by clicking the place on the map or scrolling on that area on the left. So again, it uses the same template as the staffing data. You can use this to identify overall ratings, staffing, health inspection. You can see whether there's a resident or family council. You can look at the nursing home's fines and penalties, whether it has an abuse icon. There's so much data in this file, and you can do some really interesting things with this, such as you can, when talking within your family council, you can bring up, hey, our nursing home has an abuse icon. You can understand whether a nursing home has a history of deficiencies or fines and penalties. Now, if you're an advocate or an ombudsman, you can also use this to do a little research, see if there's a certain trend going on in a city or a county. And you can talk to a legislator covering that county and bring up this data to voice your concerns. The last data set, and I'm very excited about this one, we just came out with it a couple weeks ago. It's on antipsychotic drugging rates. And just a quick story, this is from the New York Times before I get into the data, because these are people that we're talking about. There was a New York Times story a few months ago about David Blakeney, a 63-year-old resident from South Carolina. And he was restless, he was agitated, and the doctor at the nursing home wanted him on an antipsychotic medication called Haldol. Sorry if I'm pronouncing that wrong. This is a powerful sedative, but there was no evidence that this resident actually had schizophrenia, which is a diagnosis needed to prescribe antipsychotics. The short of it is 8 months after admission with a long list of ailments, including round-the-clock sedation, weight loss, pneumonia, severe bed sores requiring foot amputation, Mr. Blakeney was dead. And Mr. Blakeney's story was in some ways exceptional, but in some ways is not, because 1 in 5 residents are receiving antipsychotics, and most are not receiving them with the clinical diagnosis that that would lend itself to being prescribed antipsychotics. So these are highly potent drugs that are indicated to treat specific conditions and diagnoses, and they carry a black box warning because of increased risk of stroke, heart attack, diabetes, falls, and then diminished social and emotional well-being. These are not clinically indicated for the treatment of so-called behavioral and psychological symptoms of dementia. So a super quick quiz because we're at 156. But AP drugs should be used to sedate residents with behavioral and psychological symptoms of dementia. True or false? And the second question, AP drugs carry a black box warning because they must be prescribed to all nursing home residents. Or B, they increase risk of stroke, heart attack, diabetes, Parkinsonism, and falls. Or C, none of the above. Give it a few more seconds. I am happy with the results, and we are gonna end the poll. And looks like almost everybody got the first question right. They should not be used to sedate residents with behavioral and psychological symptoms of dementia, and they increase risk of stroke, heart attack, diabetes, and Parkinsonism. So I'm going to, in a couple minutes, do a screen share showing you how to access this data. But before I do, just how can this help your advocacy? 3 ways you can identify the drug rate at a nursing home or nursing homes and use this information when talking to staff, when talking to administrators, when talking to other family members. You can ask the administrator why this nursing home's drug rate is as high as it is, and you can voice these concerns about the drug rates to legislators in your area. And again, it's more powerful to say 33% of residents at this nursing home are being prescribed antipsychotics than it is to say, I heard there's a few people that are being prescribed antipsychotics that shouldn't be. It's really important to have this information at your fingertips. So a quick screen share. Let's get to page. This is what our antipsychotic drugging page looks like. And if you say you were interested in New York State, you would click this little New York on the map, and then you go to, I'm going to quickly, sorry if this makes people dizzy, I'm going to share, then unshare. You can go to the New York State file and look up how nursing homes are doing in regards to antipsychotic drugging administration. So for example, Holly Patterson Extended Care Nursing Home has a antipsychotic drugging rate of 19.95%. Let's see, Andrus on the Hudson has 9.09%. Apex Rehab has 34.02. Now, what's really interesting about this data set is we also include other information such as overall rating. We have some of the staffing levels, and you can really dive in to see if there's any trends and the characteristics of the nursing homes that have higher antipsychotic drugging rates. So this is now some of the nursing homes haven't reported the data, so that's why some of them are blank. But you can look and see it's color coded which ones are more likely to administer antipsychotic drugs. So I know this is a quick tour. It's hard to take everything in, but I'm going to go back to the PowerPoint, and we're going to wrap this up with a Q&A. And note, we're going to be including this PowerPoint and other resources from this presentation on our website, and you'll get an email about that in the next couple of days. So to the PowerPoint. Richard, you want to take it back over?
Sure, just 1 second. Let me start my video. Hi again, everyone. Thanks, Eric, and I apologize for hogging up the time because the data are so important and so useful, and you're doing a great job with that. So, but thank you. So our next webinar, as I mentioned at the start of the program, is Tuesday, February 15th from 1 to 2 p.m. Eastern. And we have Paula Carter, who's one of, if not the, I would say one, not the leading, researchers in the United States on assisted living. And so the topic of our webinar is assisted living, identifying policy to promote quality assurance, safety, and quality of life. It should be really good and really interesting. As I mentioned, this is something that we do work on, and we've certainly have advocated on to have better rules and standards and quality of care and safety and even monitoring in assisted living. But too often, from what we hear quite widely is that there are a lot of problems that are not addressed, excuse me. For updates and invites to future programs, please visit nursingHome411.org/join. For Ombudsman, if your program supervisor provides for credit for attending this program, please take a quick survey and it's www.surveymonkey.com/r/LTCCC-LTCOP1. And we'll leave that up there as we answer questions. And I will go through these and we'll stay on till, as I said, 2:10. And thanks everyone for your patience. We have a number of questions. So Kathy asked, should the social worker play a highly important role overseeing the quality of life and interests of the residents? And I would say my quick answer to that is yes. The social worker is an integral part of the, not the nursing care team, but I would say the overall resident care team in a facility. And that's something Eric was talking about, the data. We actually track the data for every single facility in the country for social work staff. So you can see the extent to which your nursing home or nursing homes in the area or in your area are providing social workers, excuse me, for their residents. And they really should be doing more than just kind of facilitating people coming in and out. That's kind of helping the nursing home and being more of an administrative function. They should be working to ensure that residents have a good and meaningful quality of life. Next question from Linda. How do we hold facilities accountable in this time of severe staffing shortage? My facilities are doing all they can to hire staff without significant success. The staffing is obviously a really serious issue now. However, a couple of things. One is that now, there was a study that came out last year. Our own tracking of these data, as Eric was saying, we publish them every quarter, indicates that staffing has been pretty level through the pandemic. And what that means, and there was actually a study that just talked about this, came out a week or two ago, is that staffing went down in nursing homes, as it did go down in other settings across the board, across the country. But then in other settings, staffing started to go up, but it didn't go up in nursing homes. And part of the reason for that, frankly, is yes, it's hard to get staff, but a significant part of the reason is that nursing homes have been perpetually understaffed for years. I was reading a report from 2012, 8 years before the COVID-19 pandemic, that said that there is a staffing emergency in the author's words, in US nursing homes. And of course, that has been exacerbated as everything else is during the pandemic. So how do we hold facilities accountable? It's a simple answer, but it's not an easy answer. And the simple answer is that it's not a warehouse. It's not as I said to a reporter last week, it's not a hamster farm where, the people, residents are taken in and then you just throw them some more food and change their cedar chips every couple of days or whatever. Nursing homes are obliged, as I said at the very beginning, or just kind of hinted at, and as all of the work that we talked about today gets at, nursing homes are obliged to only accept and retain residents for whom they have enough staff and enough equipment, et cetera, to provide safe, appropriate care, both clinical care and quality of life care. Period. End of story. And at what point, if you're not doing that, and if you're allowed to continue to do that during a public health emergency that's now heading towards its third year, at what point is it that you are essentially not even operating a prison, because we wouldn't allow prisons to operate this way, but operating a warehouse, you're warehousing people. So if they don't have the staff, then they have to either find a safe placement, a safe and appropriate placement for their residents, and certainly they should not be taking in new residents. And that is the fundamental issue. So next question from Susan. Do you know of any nursing homes in New York State that are the way you just described? Well, if you mean in terms of better care and staffing, one thing that, as Eric was talking about, that you can actually do is you can go to New York State. You can go to, if you're in another state, to that state's staffing file and just do a search for the hours per resident day of direct care staff, HPRD, and you can see which ones are providing high levels of staff and which ones are providing low levels of staff. And frankly, about 25% of facilities provide 4.1 or more hours of direct care staff time for their residents. So that means that it can be done. It's not just one facility or two facilities, it's 25% of facilities. The problem is that because we're trained to accept substandard care, and because our state and the states in general don't do a good job overseeing and making sure that there's quality control in nursing homes, it's left up to the owners on the honor system. And unfortunately, too many owners are just not honorable. They are just not willing to put the resources in to make sure that their residents are able to just maintain and have decent care and live with dignity. Are National Guard members receiving at least basic nurse aid training or more before going to nursing homes to augment staffing? I can't say for sure. This is from Mary Dell. I think that's a good question. There are very few National Guard people going in, so it's not really a very big band-aid, frankly, to help most of the residents. It is always incumbent, no matter what the situation. CMS, the Centers for Medicare and Medicaid Services, has said this. It's always incumbent upon the facility to have the staff that has the knowledge and the ability to meet staffing standards. And they've said this throughout the pandemic, and that is true today. So if National Guard is going in, and if they're helping residents, they either need to know the care standards, or if they're providing other services to enable more of the trained care staff to be on the floor and at the bedside, that's fine. But I think that it's certainly a very legitimate concern. Pat asks, I think we just have, I'm going to take two more questions. So Pat asked, do you have resources related to nursing home requirements for emergency preparedness plans and how resident families know what facility will do if they have to manage resources of a crisis, et cetera? So every facility for several years now has been required to have an emergency preparedness plan in place and to be reassessing that plan. I believe it's on an annual basis to make sure that it is appropriate and potentially effective. So do we have access to those resources? I think facilities should be sharing those resources and that information with the public. I do not believe, and pardon me, I'm not 100% on this, but I don't believe that they have to share those resources, but they do have to show them to the surveyors, and they have to be adequate and appropriate for their residents, for where they're situated, and for the facility and its staffing. Mary Jo asked, are the expectations for the 4.1 hours per resident day still in effect during COVID? So just to be clear, the expectation, it's not so much an expectation of 4.1 hours. It's that 4.1 hours is the amount of time that the federal study, really a landmark federal study from 2001, indicated as necessary just to meet the basic clinical needs of residents. So as a result, 4.1 has always been a demarcation point for knowing whether a facility is meeting even the clinical needs of it, no matter the emotional, psychosocial needs, all of which are important. Especially we know now after seeing what happened to residents who died of COVID, who died of loneliness, died of loneliness during COVID, who died of lack of activities, lack of care, lack of emotional and psychosocial supports. All of it is important. The 4.1, all those researchers did was look at clinical outcomes. So they didn't look at psychosocial outcomes. And that's what that means. So 4.1 is an indicator for us, but it's not in itself a standard for resident care. But so the expectations, again, as I was saying in regard to the, who's providing bedside care, whether it's National Guard, et cetera, the expectation is always that the facility has the staffing and supplies, et cetera, to meet the clinical and psychosocial needs of residents, period. And as I kind of alluded to, we now know that a lot of residents suffered and died because of lack of human care, lack of human touch, lack of activities, COVID-19 COVID-19 pandemic failures to thrive, not from COVID, but from failure to thrive due to COVID-19 isolation. So those things are all really, really important. I think we're going to have to end it there. It's 2:12. And so I'm sorry we couldn't answer more questions, but again, please join us next month. Very much appreciate you joining us. Thank you, Eric, and have a nice afternoon. You can end recording now, Eric.